Welcome to Part 2 session on infective endocarditis. In Part 1, we explored the definition, predisposing factors, and causative organisms. Today we'll dive deep into the pathogenesis. First, endothelial damage occurs. This could be from turbulent blood flow, mechanical trauma from catheters, or inflammatory processes. This damage denudes the endothelium, exposing the underlying basement membrane. Second, this exposed basement membrane promotes platelet and fibrin deposition. Remember, platelets recognize damaged endothelium and adhere to it, initiating the clotting cascade. This creates a sterile clot on the valve surface. Third, this platelet fibrin deposit forms what we call a non-bacterial thrombotic endocardial lesion, abbreviated NBTE. Think of NBTE as a sterile vegetation. It's not infected yet, but it creates a potential nidus for colonization and infection. Fourth, transient bacteremia occurs. This is the patient-related factor. Bacteria enter the bloodstream from dental procedures, skin infections, IV drug use, or any other source we discussed in Part 1. Finally, circulating organisms in the bloodstream encounter the NBTE lesion, adhere to this damaged surface using their adhesins, and invade into the NBTE. Now we transition from sterile to infected vegetation. Once bacteria have adhered to the NBTE lesion, a cascade of events leads to mature vegetation formation. First, complement activation occurs. The immune system recognizes the bacteria and activates complement proteins, triggering inflammation at the site. This inflammation leads to further fibrin and platelet deposition. More inflammatory cells are recruited to the area, and additional endothelial damage occurs at the colonization site. It's a vicious cycle. Infection causes inflammation. Inflammation causes more damage. More damage creates more surface for bacterial adherence. The critical step is entrapment of organisms. Bacteria become trapped in a thrombotic mesh composed of platelets, fibrin, and inflammatory cells. This creates what we call a mature vegetation, a complex structure of bacteria embedded in clot material and inflammatory cells. Here's the problem. This vegetation protects the organisms from multiple defense mechanisms. The bacteria are shielded from host humoral factors like antibodies, from phagocytic immune defenses like neutrophils and macrophages that can't penetrate the vegetation effectively, and critically, from antimicrobial agents. Antibiotics have difficulty penetrating this dense structure. This protection explains why IE requires prolonged courses of high-dose intravenous antibiotics, and sometimes surgical removal of infected tissue. You can't just give a few days of oral antibiotics and expect cure. As vegetations mature, they cause serious complications through three main mechanisms. First, vegetations create hemodynamic alterations in blood flow. Large vegetations can physically obstruct flow through the valve. Imagine a mass partially blocking the valve opening. They also increase turbulence, making the flow even more chaotic and potentially damaging more endothelial surface. Second, if the infected vegetation goes untreated, progressive tissue destruction occurs. Neutrophils attempting to fight the infection release enzymes. Bacteria produce toxins and enzymes. Together, these factors disrupt elastin and collagen, the structural proteins of the valve. This leads to valvular destruction. When valves are destroyed, they can't function properly. Regurgitation occurs. Blood flows backward through the damaged valve. This causes heart failure symptoms, like shortness of breath, which we saw in our case patient from Part 1. Third, embolization is a devastating complication. Parts of the vegetation can break off and travel through the bloodstream. These emboli lodge in smaller blood vessels, causing obstruction and establishing secondary sites of infection. Common embolization sites include the brain causing stroke, spleen causing infarction, kidneys causing renal impairment, and extremities causing ischemia. This flowchart elegantly summarizes the entire pathogenesis we've discussed. Starting at the top, endothelial injury leads to platelet fibrin clot formation, creating non-bacterial thrombotic endocarditis, or NBTE. Then transient bacteremia introduces organisms that adhere to and proliferate within the NBTE lesion. This creates mature vegetations, which lead to two major complications shown at the bottom: valvular destruction resulting in valve dysfunction and heart failure, and embolization causing stroke, organ infarction, and metastatic infection. Now let's explore how infective endocarditis presents clinically. The manifestations result directly from the pathogenesis we just studied. Systemic symptoms reflect ongoing infection and inflammation. Fever is the most common presenting symptom, present in about 80 to 90% of cases. It's usually low-grade but persistent. Weight loss occurs due to chronic infection and increased metabolic demands. Headache can result from fever, emboli, or immune complex deposition. Musculoskeletal pain affects joints and muscles, often mimicking arthritis. Cardiac manifestations. A murmur is heard in 85% of cases. This could be a pre-existing murmur from the predisposing valve disease, or a new murmur from vegetation or valve destruction. A changing murmur, one that sounds different from baseline, is particularly concerning and suggests progressive valve damage. Peripheral stigmata are classic physical findings, though they're less common now with earlier diagnosis and treatment. These include petechiae, small hemorrhagic spots from septic emboli or vasculitis; Janeway lesions, painless hemorrhagic macules on palms and soles from septic emboli; Osler nodes, painful nodules on finger and toe pads from immune complex deposition or septic emboli; splinter hemorrhages, linear hemorrhages under the nails; clubbing of fingers from chronic infection; neurologic manifestations from cerebral emboli causing stroke or immune-mediated meningitis; Roth spots, retinal hemorrhages with white centers; splenomegaly or splenic infarction from emboli to the spleen. This slide shows the classic peripheral stigmata of infective endocarditis. Let me describe what you're seeing. Splinter hemorrhages appear as linear red-brown streaks under the fingernails, resembling wood splinters. Conjunctival petechiae are small hemorrhagic spots on the conjunctiva of the eye. Roth spots are seen on fundoscopic examination. They're retinal hemorrhages with pale centers. Mitral valve vegetations are visible on echocardiography as irregular masses attached to the valve leaflets. Osler nodes appear as tender, raised nodules on the finger pads. Janeway lesions are flat, painless hemorrhagic lesions on the palms or soles. Remember the key distinction. Osler nodes are painful, Janeway lesions are painless. A helpful mnemonic, Osler equals ouch, because they hurt. These findings are less common in modern practice because we diagnose and treat earlier, but they remain important clinical clues when present. Blood culture is the most important diagnostic test for infective endocarditis. Let me emphasize this again. Blood culture is essential and must be done correctly. The protocol is specific. Obtain 3 sets of blood cultures within the first 12 to 24 hours. Each set should be separated by at least 1 hour, and each set should be obtained from different venipuncture sites. Don't use the same IV line or site repeatedly. Why 3 sets? Multiple cultures yielding the same organism provide strong evidence of intravascular or intracardiac infection rather than contamination. If all 3 sets grow Staphylococcus aureus, that's real bacteremia. If only 1 set grows coagulase-negative staph, that might be contamination from skin flora. The timing is also crucial. Spread cultures over time to demonstrate continuous bacteremia. In IE, bacteria are constantly being shed from vegetations into the bloodstream, so bacteremia is continuous, not intermittent. This distinguishes IE from other sources of bacteremia. Obtaining cultures before starting antibiotics is absolutely critical. Once antibiotics are administered, organisms may not grow, even if infection is present. Our case patient from Part 1 was managed correctly. Cultures were obtained before empiric antibiotics were started. This simple test, blood culture, remains the cornerstone of IE diagnosis. Everything else supports it, but blood culture provides the definitive microbiologic diagnosis. Proper blood culture technique is essential to get accurate results. Let's review the key points. Precautions include strict aseptic technique. Disinfect the skin thoroughly at the venipuncture site using alcohol followed by iodine or chlorhexidine, allowing it to dry completely. Also disinfect the blood culture bottle septa before inoculation. These steps prevent contamination from skin flora. Volume matters significantly. A minimum of 20 milliliters should be obtained per set for adults. That's 10 milliliters per bottle, since each set has an aerobic and anaerobic bottle. More blood means more organisms captured and higher sensitivity. Incubation duration is important. Bottles should be incubated for 7 days before declaring them negative. Some fastidious organisms grow slowly, so premature reading as negative could miss the diagnosis. Once organisms grow, isolation and identification follow standard microbiological protocols depending on the organism. Common organisms like Staphylococci and Streptococci are identified within 24 to 48 hours. These technical details matter because improper technique leads to false negatives or contamination, potentially resulting in misdiagnosis or inappropriate treatment. Despite optimal technique, approximately 5 to 10% of IE cases have negative blood cultures. Let's understand why. The most common reason is prior antibiotic treatment. If the patient took antibiotics before blood cultures were obtained, organisms may be suppressed and won't grow. Always get cultures first. Fungal endocarditis, particularly Aspergillus. Fastidious and nutritionally deficient organisms grow poorly on standard culture media. This includes the Hackett group. Also nutritionally variant Streptococci that require special media. Cell wall deficient organisms like Mycoplasma can't be detected by standard culture methods. Obligate intracellular organisms, including Chlamydia psittaci and Coxiella burnetii, can't grow on cell-free media. They require cell culture. Immunologic factors, such as antibodies coating circulating organisms, may interfere with culture. Subacute right-sided endocarditis can be culture negative because organisms are filtered out in the pulmonary capillaries before reaching systemic circulation, where we draw blood. Culture negative, i.e., requires alternative diagnostic approaches. When blood cultures are negative but IE is suspected, we use alternative diagnostic methods. Serology detects antibodies to specific organisms. For Coxiella burnetii, which causes Q fever endocarditis, we measure IgG antibody titers using immunofluorescence assays. For Bartonella species, we use immunofluorescence assays to detect IgM and IgG antibodies. Immunohistology involves examining surgical tissue from valve replacement or autopsy, using special stains and antibodies to identify organisms directly in tissue. PCR of surgical tissue amplifies bacterial DNA, allowing identification even when organisms won't grow in culture. This is particularly useful for Tropharima whipli, which is non-cultivable. It simply cannot be grown using standard techniques. The combination of serology, molecular methods like PCR, and histological examination of tissue allows diagnosis even when standard blood cultures fail. However, these tests are typically performed in reference laboratories, and results take longer, which is why empiric antibiotic therapy is often necessary while awaiting results.